All right. Good afternoon, everybody. And again, thank you for joining today's presentation on updates on infection control for residential providers. My name is Boris Vilgorin. I'm with MICTAC, the Managed Care Technical Assistance Center, and I'm joined by my colleague, Kevin. And also happy to say that we're joined today by a number of individuals from OMH who will be doing today's presentation. But before we jump into the presentation, just wanted to do a little bit of housekeeping. Wanted to mention that this presentation is being recorded, and both the recording and the slides will be made available. We also want to encourage folks to ask questions, and the way you can do that is by using the chat option in WebEx. So please feel free to chat the questions throughout the presentation. And then we hope to have time at the end to answer as many questions as possible, using the questions that have been chatted. And so, again, just wanted to say thank you for joining today's presentation. And with that, I will turn this over to Moira, who will do some of the welcome and introducing herself.
Hi, everybody. Thank you, Boris. My name is Moira Tashin. I'm the Associate Commissioner for Adult Services. I'm being joined today by Dr. Kasoy, who is part of our medical team who works with us statewide on all of our community concerns. Also, Donna Bradbury, who's our Associate Commissioner for Children's Services, and Christopher Smith, who is the Deputy Director for Adult Services. Again, thank you, and thank you for all the time you've spent serving individuals in very unique ways during this pandemic. We also want to recognize all the challenges that you and your staff have personally and professionally been enduring over these last number of months, as well as the consumers in which you are serving. Thank you on behalf of the Commissioner and all of OMH. This afternoon, what we want to do is to have a conversation with you about the cluster system and updates on infectious control. It's our hope that we'll be able to continue having dialogue within the coming weeks and months as well. We're putting together some sort of forum that we can have open dialogues with you, and more information around that will be forthcoming. We look forward to your questions at the end of the presentation. So for now, what I'd like to do is turn this over to Dr. Kasoy, who will really walk us through the updates on infectious control. Dr. Kasoy?
All right. Thank you, Moira, for that introduction and for all that you do at the Office of Mental Health. Thank you, Boris and Kevin, for helping us navigate this platform so we can present this update today, and but most importantly, thank you to all the folks who are listening in for all the work that you've done in keeping your residents safe and healthy, as much as possible during this extremely challenging these last 8 months. This is unprecedented. This is a massive crisis, and you kept this together through, sweat, blood, tears, and we're deeply, deeply appreciative of all that you do. We presented like this sometime in the end of March, and since then we've learned a lot about this terrible illness. So we just wanted to give an update as we're headed into the winter. And to have an opportunity to answer your questions about just basically the science and infection control aspects of this disease. But really, any questions that you may have, we're eager to try to answer. So next slide, and one more. Okay. So just to begin off, a lot of this material, most of you will already know. But just to level set and make sure that we go through all the basics. COVID-19 is caused by a SARS virus, and symptoms of COVID usually appear 2 to 14 days after the exposure. So before 2 days, hard to have symptoms. After 14 days, very unlikely it's possible. But if folks are going to become symptomatic, are going to develop the symptoms of this illness, it's going to be within 2 to 14 days of exposure, which is reassuring because it gives us a pretty clear window of when to be on alert. Fever is often a common symptom, and for the purposes of this illness, we're considering fever to be 100 degrees or greater. So that's something to look out for. People can have subjective experiences of fever. You know, anyone who's had the flu or a bad cold have experienced this. Malaise and fatigue and achy muscles, chills or tremors. All these, can be part of the symptom cluster, even if the temperature is below 100. COVID is predominantly a respiratory illness, so it's very common to have respiratory symptoms, such as a sore throat or a cough, shortness of breath, and then in sort of more serious situations, difficulty breathing or lowering of the oxygenation of the blood. So those are more concerning respiratory symptoms. Less common symptoms include a runny nose or a headache, GI problems such as nausea, vomiting, diarrhea, and then the famous loss of taste or smell, which is so distressing for so many people. There are other symptoms too, but these are the more common ones. Next slide. So how is COVID transmitted? So first and foremost, COVID-19 is transmitted through the air by little droplets of spit that come out of people's nose and mouth. This happens mostly when people sneeze or cough or yell or, sing or laugh, play the trombone, play the trumpet, but it can also happen when people talk. And when people are doing these activities in enclosed, unventilated spaces such as a car or an office, that COVID can also become aerosolized, which means that it's not only spread by flying little, droplets of spit, it also just kind of like hangs out in the air and just sort of floats in the air, and can saturate the space. We know that there's an unknown percent of individuals who become sick with COVID-19, who are able to spread COVID-19, but never develop symptoms. So this is one of the greatest challenges we face with this particular illness, because there's people out there who are infecting others and they don't know themselves that they're sick. So these asymptomatic spreaders are a big problem. That's why we all have to adopt prevention measures, because symptoms are not enough to figure out who is sick and who is infectious. So it really has to be everyone adopting these prevention efforts. And then a secondary way of transmission, much less important than the air, but also prominent, is that COVID-19 can quote unquote survive for a period of time on different surfaces. And then when other folks come around and touch that surface, and then with that hand touch their mouth or their nose or their eyes, they can become infected that way. So that's why we say, avoid touching your face and wash your hands a lot. COVID-19 does not get transmitted by going through the skin. It's when you use your hand to touch your nose or your mouth or your eyes that you bring COVID to you. So important to have hand hygiene, important not to touch your face, and important to disinfect commonly used surfaces to help reduce the risk of that contact transmission. Next slide. Okay, so this is kind of a disgusting slide, but I think it's important to show. And this refers to the size of the droplets and matter to how far the illness spreads. So for example, the measles virus can survive in much smaller droplets. So that's why it's so contagious. The droplets become aerosolized and measles is easily spread. Ebola, on the other hand, can only survive in much larger droplets that, when someone produces them, they kind of fall to the ground because of gravity. So while it's a deadly illness, it's a lot less infectious than measles. COVID is somewhere in between, and we recommend a distance of 6 feet because by some initial studies and observation, that's the recommended distance that you have to maintain from people to reduce the risk of having one of these sort of droplets of spit land on you and transmit that disease. So how big are we talking about in terms of these little droplets? I mean, we're really talking about microscopic here. If you look at your pinky finger, it's about 1 centimeter across. If you divide that 1 centimeter across your pinky finger into 10,000 equal slices, so teeny, teeny, tiny, that's about a micron. A droplet that can transmit COVID and travel is around 10 microns, so 10 of those little slices. Droplets that are under 5 microns can become aerosolized. If you take one of your hairs and look at the width of your hair, that's about 125 or somewhere between 125 and 150 microns, depending on the hair. And so we're talking about very, very, very small little droplets that spread when people cough or sneeze or play the trombone or whatever it is. So you can't see it, so it's important that you take the measures to protect yourself. Next slide. So how do you prevent transmission? So the goal here is to have as many people as possible adopt as many prevention measures as possible to slow the spread as much as possible. The slower this spreads, the fewer people will get sick. So if one person transmits to one other person, you'll have the same number of people who are sick and infectious in the community. If it's less than, if one person is transmitting to fewer than one people, right, statistically, population-wise, the numbers in the community will fall and fewer people will become exposed and fewer people will get sick. So we want to slow the spread as much as possible by adopting as many of these measures as often as possible by as many people as possible. Most important thing is you want to put a physical barrier between the back of your throat and the world. Why? If you put that physical barrier and you're one of these asymptomatic carriers, if you cough, sneeze, talk, whatever, most of those droplets will be caught in that mask, that facial covering. If you're not sick and you're out and about in the world and there's someone who is an asymptomatic carrier and they sneeze or cough, well, there's the mask between the back of your throat and the world. That'll keep you safer. Why do I say the back of the throat? Because that's where the infection first takes root. So when you wear a mask, you want to have it cover your mouth and your nose. Because as you see in this picture, your mouth and your nose connect at the back of your throat. So if you have a mask that's only covering your mouth, you're still very exposed. And you're still exposing people in case you are an asymptomatic carrier. So you got to cover both. Otherwise, it's almost as if you're not wearing a mask at all. So you want to put that physical distance, that physical barrier between the world and the back of your throat. Like physical distancing, super important. Keep that 6 feet to reduce the risk that one of these flying droplets will land on you. If you're going to be indoors with people, and most of us are because it's winter, increasing ventilation helps reduce the risk that the air will become saturated with these teeny tiny little droplets, and when that happens, everyone is at increased risk of becoming sick. So cracking open a window, leaving a door open, boosting your sort of ventilation to help air circulate, bring in outside air. That's really, really important and helps reduce the risk of transmission. Again, rigorous hand hygiene, not touching your face, super important. And we're also really recommending that everyone gets the flu vaccine and gets everyone in their lives to get the flu vaccine. Why? Flu and COVID can have similar symptoms. If you get the flu, you'll be really worried about having COVID, and there's all these things that you have to do if you're worried about having these symptoms. But more importantly, if you can have both the flu and COVID, and then you're at much higher risk of having a terrible outcome, hospital, serious illness, death, than if you had been protected from influenza by the flu vaccine. So this is a really important thing you can do to reduce your risk of a bad outcome. Talk to your clients about this, talk to your families about this, talk to your coworkers about this. Flu vaccine this year is super important. Next slide. So just in terms of infection control guidance, on the Office of Mental Health website, you'll notice that there's a brand new version of the infection control manual. We really recommend everyone to look through, read it, see how it applies to your programs. There's a section specifically for residential programs that's updated and has a lot of good information. These slides take some of the information from the manual, but the manual is really where most of the good information is. So take a look at it. Make sure you're educating residents and staff about physical distancing, wearing that facial covering, keeping good hand hygiene, super important. On the manual, there's a link to the Department of Health website where you can find and print out really great posters that you can post around your facility to help remind people to be safe. You can even post it around your house to help remind your teenage kids to be safe. So it's a good resource. Disinfect frequently those surfaces that come into a lot of contact: tables, doorknobs, light switches, toilets, sinks, and so forth. So make sure you're always sort of cleaning, rubbing those down, killing off that virus on those surfaces that might increase transmission. Remind your residents and your staff to report symptoms as soon as possible and follow the quarantine and isolation guidance, because that will help keep everyone around them safe, their loved ones, their clients, their friends, their peers safe. In the physical plant, you might have to change around the furniture and sort of put tape on the ground or do different things to help remind people to maintain physical distancing. So different programs, of course, have different physical plants. So, creativity is important here. And again, I can't emphasize this enough. Get your flu vaccines because this will save lives this year. Next slide. Okay, so this I cut and paste directly from the manual, but I just want to point it out. So what happens if your staff have a close exposure or a close contact with someone who is known to have COVID or is strongly suspected of having COVID? If your program is having staffing shortages and you've exhausted other options about how to fill those staffing shortages, and most programs are having staffing shortages, those folks with close contacts can continue to work, provided that this has been reviewed with human resources and the local health department, and that the individual is deemed essential for the operation of the program. So it's really important that this person is asymptomatic, that they're following really closely all the public health guidance about mask wearing and so forth. They need to check their temperature twice a day, either with their own home thermometer or with a thermometer that the program provides. Either one is okay. But if their temperature goes above 100 at any point, then they're considered to be positive and they can no longer come to work. If they develop any other symptoms while they're working, they should go home to reduce the risk of spreading the illness to everyone else. Lots of information on how to manage staff who come into close contact with other folks who are sick or who are sick themselves. Happy to answer questions about that, but definitely take a look at the manual. Next slide, please. So everyone, I'm sure, has heard about the strategy that's been implemented by the state on defining different zones as different colors. So here on the map, you see a yellow precautionary zone and an orange warning zone, and hopefully we won't have very many red microcluster zones. But on the New York State Forward website, you can put in the address of your program or your home or your kid's school or whatnot, and see whether or not that particular address is in a particular zone. And you can take the appropriate precautions to make sure that you and your loved ones and your residents and your peers and so forth are safe. So we recommend checking that out and looking at that information. Next slide. So we're using the cluster system to help inform programs of when to adopt enhanced precautions, when to make sure that they're implementing extra safety in their programs. So if your program is in a red or an orange zone, or if your program has a cluster of 2 or more cases in residents or staff, or if your local health department, or if we at the Office of Mental Health, say to you at a particular program, you guys should step up the level of caution, be extra careful, be extra safe. Then programs should develop, should implement sort of enhanced precautions and how they're operating. And then we encourage programs to keep those enhanced precautions for at least 2 weeks until after those conditions are no longer met. As you remember, most symptoms appear within 2 to 14 days of exposure, and this will give you a good sense whether or not your program is still at risk of having sort of asymptomatic transmission, people popping up sick, and so forth. So we'll go into what enhanced precautions mean for residential programs in a little bit. Next slide. So for staff, we really say that staff must wear a mask covering their nose and mouth the entire time while they're on shift, especially when interacting with residents. The only time a staff member, it's okay for a staff member to remove that mask is if they're in their own office alone and with the door closed. Then they can take the mask off. But if they're sharing an office, they should continue wearing the mask, even if the desks are 6 feet apart. It's not masks or physical distancing. It's always both masks and physical distancing, not one or the other. So if you have staff who share offices, they both should wear a mask. You might have seen the Department of Health this last weekend issued a guidance that they're encouraging all staff that interface with patients or residents or clients to also wear a face shield. It's something that the Department of Health itself has recognized that it's going to be difficult for different programs to implement because it's hard to access PPE and so forth. If your program has the ability to give face shields to staff, that's something we encourage. But if that's not something that's possible, then we encourage everyone to double down on wearing the mask, maintaining physical distancing, hand washing. What the face shield does is it reduces the risk of that droplet flying through the air and landing in someone's eye. So even without a mask, as long as everyone can maintain physical distancing and so forth, even without a face shield, as long as everyone can maintain physical distancing and so forth, that makes everyone safer. If you can give the extra safety of a face shield, we recommend that, but we know that's very difficult for programs to access. So that's just to clarify this guidance that just came out from the Department of Health. Happy to answer questions about that towards the end. Next slide. Testing. So testing is our friend. There's two types of tests. One is a diagnostic PCR test. That's the gold standard. A positive or a negative result is something that you can take to the bank. It's possible that there's errors, but those are very, very rare. And you can find information on the Department of Health website on where to access a PCR test. The PCR test is much more accurate, but it's much slower, and the sample has to go to a lab with specially trained technicians to process, and the results can take anywhere from a day to a couple of days, maybe even to a week to come back. So that's not always something you can act on immediately. There's also a bunch of rapid tests that are popping up where the results come back within minutes to hours. Lots of primary care offices are implementing this. Pharmacies might be implementing this, urgent care centers. These tests give you much faster results that you can use to make decisions and take actions, but they are less accurate than the PCR tests. Any positive results on the rapid test should be considered true, but you should also get a PCR test to confirm the results. A negative rapid test is something that you can act on, but if you are having symptoms, if you are unclear as to if you've had a new exposure, just repeat that rapid test or go for the PCR test. These tests are good to have to make quick decisions, but if you have to make a really important decision, a really weighty decision, go for the PCR test. But for screening purposes, for determinations of whether or not something is COVID or not, these rapid tests are very useful. Okay, next slide. All right, one more. Just to get into some guidance specific to residential programs now. In terms of infection control, we really encourage all residential programs to double down on education about COVID precautions. We're all tired of COVID, of mask wearing, of distancing. This has been a long slog, a drag. It's going to go on for a while. It's going to be a tough winter. This is not the time to get complacent or get tired. Really remind folks, double down on the vigilance. There is an end in sight, but we're not there yet. So just raise the volume on that. If your particular program offers groups, and you're not in a moment of enhanced precautions, if you're just following standard precautions, make sure that if you're having indoor groups, there's no more than 10 people in the room, including the facilitator or facilitators. The room has to be well ventilated, and everyone has to be able to be at least 6 feet apart. Everyone should be wearing masks correctly. If the room is not big enough for 10 people to be 6 feet apart, then you got to reduce the size of the group. And the groups cannot last more than an hour. And then in between groups, make sure you air out the room so people aren't breathing each other's air. If you're going to have organized outings, make sure that they're only to well-ventilated locations where people can maintain distancing, and consider the risks of long vehicle rides. So we really don't want people to be sort of put together in vans, for long rides. That's a space where the virus can easily become aerosolized. So that's something to consider. We have the holidays coming up, so especially for residential programs that serve kids. People want to be with their families for the holidays. There's lots of risk here. So one thing that we're encouraging is partner up with the healthcare providers or the local health department, in your communities to get that rapid testing as much as you can, either before the kid goes to visit their family, to reduce the risk that the kid is bringing the virus to the family and possibly exposing the family members, or when the kid's coming back to see if the kid might be bringing the virus back to expose other kids or staff members in the program. So think about implementing testing if you have clients who want to go visit their family members for the holidays. Using the testing will help you make decisions, will help reduce the risk to everyone, both in the program and at the family. Next slide. So we are encouraging residential programs to keep accepting new clients. Even during this time, folks need a home. It's absolutely okay, and we recommend that programs require an attestation from the referring facility that the resident has not had any new COVID-19 symptoms, so that no one who's symptomatic is coming into the program. If a referral is from a hospital, whether it's a psychiatric or a medical hospital, programs are allowed to require a negative test within 72 hours of transfer. If the resident is coming from a different referral source, maybe another residential program or the community where it's not so easy to get testing necessarily, then that test cannot be required. But for any referrals from a hospital, programs are allowed to require a negative test before transfer. If someone has been sick has had COVID previously, maybe 3 weeks ago or whatnot, and they're better now, the testing might stay positive as long as they've sort of gone through that window of isolation and quarantine. That's okay. This information is all listed in the manual, and we're happy to answer questions about that too. So if possible, and we know this is very difficult for many programs, any new residents should have their own room and always wear a mask for the first working day. If it's not possible, it's not possible. But if it's something that you are able to do, it'll help keep everyone safer. And then new residents should be encouraged to stay in their room as much as possible for the first working days. If you can help them eat their meals in the room, that is a plus. And help maintain a distance of 6 feet from everyone else. This is difficult, but as much as it can be done, it'll keep everyone safer. Next slide. Okay, so it's very likely that a particular resident will become sick, will develop symptoms. I'm sure most of you have gone through this before. If someone develops symptoms, they should be asked to stay in their room as much as possible. Ideally, if possible, they should stay in a single room. If possible, any exposed roommates should have also their own room for 14 days. Try to help the residents take meals in their room, and really encourage mask wearing. We know that for the most part, small residences that have the same clients, the same residents, that's the bubble. So staff should always be wearing masks, but residents might not want to wear masks around each other, especially if they see themselves as housemates, as roommates. But for folks who have developed symptoms, really encourage these folks to wear a mask. We want as many people as possible wearing a mask, but especially if someone is symptomatic. Immediately call your local health department for information on testing and help with testing. The local health department might want to talk to you about internal contact tracing. Lots of information about that on the OMA's website. Call your field office for extra guidance, extra help. In most cases, people will not need to be hospitalized, but if someone is having trouble breathing or looks critically ill, or if you're really worried about them, okay to send them to the hospital. Just call ahead, let the hospital know that someone with suspected COVID is coming their way so that they're ready to receive them. If one or more residents test positive for COVID or have suspected COVID, it's okay for them to share a room. And this is a way to help isolate as many people as possible so that it doesn't spread to uninfected roommates. And talk to the clinics, talk to the providers about getting nicotine replacement for the smokers. Be liberal with this so that folks aren't walking through the residence, back and forth to smoke their cigarettes outdoors. This will help folks stay in their room and be as comfortable as possible. Next slide. Remind your more vulnerable residents who are 50 or over or have medical problems to be extra careful. If someone develops symptoms in the residence, double down on cleaning and sanitizing surfaces and make it 3 times a day. Just really, go nuts with it. There's no too much. Just try to keep as many surfaces clean as possible. If you have several bathroom facilities, set one aside for people with symptoms or who test positive, and make that the bathroom for folks who are symptomatic, and have everyone else use a different bathroom. Try to have the surfaces sanitized after each use. Leave the windows open if there are windows to the outside to help reduce the aerosolization. If you only have one bathroom in the program, it's super critical to disinfect. Try to leave the fans on and the windows open. After someone showers, make sure all the steam is gone before the next person uses the bathroom. Unless the person is showering, everyone should be wearing a mask in the bathroom. Try to stagger shower times. Keep the fan running. Do everything you can to clear out that space as much as possible. That will reduce the risk of people getting sick. And anyone who tests positive or has symptoms should not be using shared spaces, like the common room or whatnot. It's okay for folks to go outside if they want a break from their room, but they should not be in indoor shared spaces as much as possible. So we know it's hard to get folks to cooperate sometimes. Okay, next slide. So when folks come back from the hospital, and we know that our residents, sometimes need medical or psychiatric admissions, even if they didn't go for COVID, it's possible that they might have been exposed to the virus while they were in the hospital. And it's possible for folks who go to the hospital because of COVID to still have some symptoms when they come back. Because the hospital may need the bed. So these folks, whether or not they went to the hospital, for COVID or not, if they develop COVID symptoms, they should stay in isolation for at least 14 days since the symptoms first began, until they've been without a fever, or having no need for fever-reducing medications for 72 hours, and if their other symptoms have improved. So improvement in symptoms or 14 days since symptoms first began or the first positive test. So you really want to give that time for the illness to progress and for that person no longer to be infectious. Folks who come back from the hospitals might be scared. So, really work with staff and residents to address their concerns and address their fears about COVID transmission. These are scary times. And anyone who comes back from the hospital, even if without symptoms, consider them to be almost a new resident and ask them to stay in their room as much as possible for the first 14 days. That will help keep everyone safe. And we know this is hard. People do not want to do this. We know in the community outside of these residential programs, folks are not really doing this. People want to go to bars, people want to go to malls, people want to go to movies, and our folks do also. But it's all about education, encouragement, and reminding folks and doing the best you can. Anything that you do is a plus. And trying as hard as you can is a plus. But we know that people just don't want to be in their room. And so really we encourage programs to do their best and work with residents to keep people as safe as possible. Next slide. So for scatter site housing programs, educate your clients about avoiding indoor socializing, about risks of having visitors, remind them about hand hygiene, about facial hygiene, basic cleaning to clean the surfaces, and if they're out and about in public, keeping 6 feet away from everyone else. You got to decide on a case-by-case basis whether or not to continue visiting the client in person or switching to kind of like a telehealth modality. If the resident needs help with accessing meds or food or basic supplies, then, you got to continue in-person visits to help make sure they don't sort of decompensate. And staff who go, should always be wearing a mask. If possible, if it's available, a face shield, and always use an alcohol-based sanitizer before and after entering or leaving the resident's home. And while they're there visiting the resident, keep that 6 feet distance. Though it's not always easy, but they should really try to do that. Next slide. So enhanced precautions. If your program is in one of those orange or red zones, or if the local health department or OMH say, be careful, or if you have a cluster, really take on these enhanced precautions. So the first thing you should do is cancel your indoor groups. It's really not worth the risk. For the hardy souls who can do outdoor groups in the winter, that's fine, but really don't do the indoor groups anymore. The Department of Health issued guidance on visitation. So programs in enhanced precaution should suspend visitors to residential congregate facilities, except when medically or clinically necessary. Necessary for a legal reason, or if you have someone who has an intellectual or developmental disability and they need an essential companion. So that's not the case for most of our programs, but definitely for some. And this applies to licensed residential programs, Article 31 hospitals, crisis residences, and residential treatment facilities. You want to suspend recreational outings if you're having enhanced precautions. It's just not safe to do so if there's community spread in your community. Work with the local health department or a local provider to obtain testing, rapid testing or diagnostic testing, and see if you can arrange for the provider to do a home or other visit to your program, and recommend to your staff, if it's feasible, if your program is able to do this, to implement a face shield, in addition to wearing the mask. Though we know that it's hard for a lot of programs to access this. But if it's not possible, really double down on the mask wearing, on the hand hygiene, on the physical distancing. I think this is the last slide. Is there one more? No, I think.
No, I believe that is it. Yep. This is it.
Okay, so we can open up to questions.
All right. Thank you, Dr. Kasoy, and thank you, Moira, as well. Just as you said, we definitely want to turn to questions now, and I want to just again invite folks to chat in your questions. We do have a little bit time left, so we'll try to get to as many questions as possible. So let me just take a look. We do have a couple of questions and others that are coming in, so let's just jump right into it. So we have a question from one of the participants that says, if a consumer is already admitted to your program and are being sent home after the admission, can the program require a negative COVID test before having the consumer return to their home?
So you can't require a negative test if the person already lives in your program. If you're getting a referral from a hospital, you can require a negative test. You can, sort of work with the local health department or a local provider to sort of help people access testing. If someone is going home, we would encourage, the programs to help these individuals access the testing, but it can't be required before someone returns because they live in the program. So they need to be able to get back to the place where they live. I just want to open up to Moira. Anything to add to that?
Yeah, Dr. I just wanted to add, one of the things that, we have learned is that even individuals who are past a contagious period may still be coming up as positive. So if someone was in the hospital and being treated and coming back to their home, that positive test may take a long time before it goes to a negative test. Do you want to explain a little further there, Flavio?
Sure. Yeah, that's a good point. Okay, so if someone is being referred to a program, the program may require a negative test. But if someone is in the hospital for COVID, say they've been 2 weeks in the hospital, they no longer need fever medication, their symptoms greatly improved, it's been 2 weeks since they first tested positive, the second test may still be positive, but that's not because the person is sick or still contagious. It's because the test is so sensitive. So it's okay to accept these individuals. A residual positive test doesn't mean the person is sick. But on a case-by-case basis, programs are welcome to reach out to, the field office or the local health department to discuss these. If someone has never had a positive test before and they have a new positive test, then it's okay for programs to ask for that isolation period. But if individuals have already gone through the isolation period in the quarantine and they've completed it and their symptoms improved and they're no longer needing fever medications, then the residual test is just picking up little dead pieces of RNA fragment and not live virus.
Excellent. Thank you. Thank you for that explanation and that answer. There's a couple of questions about the slides and the recording. So want to remind folks, we are recording this, and both the recording and slides will be made available to folks. So just wanted to cover that. We have a question, just a clarifying about enhanced precaution, and the individual just wants to make sure if they heard it correctly, that it's to be used when it's in an orange or just when it's in red status?
It's red or orange.
Okay.
If there's a cluster in the program of 2 or more cases, in staff or clients, or if the local health department or OMH says, you know what, take the enhanced precautions for now because it looks something is risky. But definitely red or orange.
Got it. Thank you. I have a question related to the RTF. The question is, how should we manage home visits? For example, for weekends and holidays, I guess the youth or the child might be going home. The person currently works in an RTF. So the question is about home visits.
So I think you got to think about this sort of clinically and risk benefit, right? So in many ways, you got to weigh the risk of infection against the benefit of the home visit clinically for that individual. we encourage programs to work with a local health department or a local provider to implement some testing, either before the youth goes home to protect the family, or when the youth is coming back, or shortly after the youth comes back to protect the facility. We know that this is difficult to implement, and not every program is going to be able to do this, but this will give you sort of more information on how to and how to decide how to mitigate risk. If testing is not available, then when the youth comes back, really encourage that youth to wear the mask, stay in their room, sort of work with that youth as if they were a new resident. But again, if think about it clinically with your clinical staff, weigh the risks and the benefits, and make a deliberate determination on a case-by-case basis. Thinking about the medical comorbidities of that young person or the family. Is there someone in the family who has severe lung disease, right? So that needs to be taken into consideration, and just go case by case and make a clinical determination. There's no hard and fast rule, and testing can help sort of make that decision if it's available to you.
And I'm sorry, Boris. This is Donna Bradbury from the Children's Division, and I thank you, Dr. Kasoy, and I agree completely. And I would add too that programs consider use of technology as an alternative to in-person visits and home visits, and make good use of the opportunity for families to connect on video platforms with the youth and residents, and also just as we provide psychoeducation to our families, provide education to families about, as Dr. Kasoy said, the risks and benefits of visitation at this time. Thank you.
Excellent. Well, thank you. Thank you both for the answer. So there's a question about, again, enhanced precaution and suspended recreational outings. It happens that it comes from somebody in an adolescent crisis residence, but I think this question probably applies to all. And just clarification, just so if you're not in an enhanced precaution, does that mean that you do not need to suspend recreational outings? I guess the other way to say it is you can do recreational outings as long as you're not in an enhanced precaution status? Yeah,
so right. So for programming, these outings are okay, provided that there are only two places where there's good ventilation, where there's the possibility of maintaining distancing, where it's easy to keep hand hygiene. The places should be not sort of like closed off, risky places where everyone is going to be sort of grouped close together, right? So, and also think about the risk of like a van ride, so, we don't want these recreational outings to require long closed automobile rides where everyone's breathing each other's air. So think about it in those terms. But if it's an outdoor place, or if it's a place that people can walk to, and it's easy to keep your hand hygiene and distancing, and it's easy to maintain the mask, that's okay. If you're in an orange or red zone, where there's a lot more community spread around you, keep your folks safe, keep them close, reduce the visitors, reduce people leaving the property, just to reduce that risk of contact. But if you're not in enhanced precautions, it's okay to keep the recreational outings. Just do it smartly. Just do it in a way that doesn't increase people's risk.
Got it. Thank you. We have another question, just again clarifying about the face shields, and especially as it maybe relates to scattered sites, or community residents, and is the recommendation that the staff wear face shields in those settings?
Yeah, I mean, the DOH recommendation is that any person who comes into contact with a patient or client, should wear a face shield. But they themselves recognize, the DOH recognizes that it's very difficult for programs to access face shields and PPE. So, if your program has the ability to acquire face shields or goggles for your staff, by all means. If not, double down on the physical distancing and the mask wearing. Again, it's not face shields or masks, right? It's face shields and masks and physical distancing. The face shield creates that little extra barrier that keeps the droplets from landing in your eye. So that's a plus. But if that's not possible, it's just make sure you do everything else really well.
Got it. Thank you. I know this is probably a little bit of a tricky question, but I know it comes up constantly when we talk about precautions in general. And of course, somebody wants, if there's any advice on if individuals, meaning clients, residents, are refusing to wear a mask. Understanding these are really behavioral issues and other things going on, but if there's any thought or suggestions.
Yeah, I mean, so many people in our society are refusing to wear masks, and and of course we're going to see it in our programs too. I mean, I think the approach that I would take is to figure out why. Is this because they don't like the masks, or because it's a political statement, or is it personality driven, or what's happening, and try to use like a motivational interviewing approach and try to work with them to align with whatever their goals are. That said, we haven't been able to get a significant chunk of society to wear masks, and we're not going to be able to. So everyone else has to be extra cautious around these people, right? So for the staff and other residents, remind them to stay away from these individuals. 6 feet, everyone should always be wearing a mask when close to these folks. Make sure that whenever you come close to these folks, you wash your hands. It's like, do what you need to do to keep yourself safe, understanding that there's going to be a chunk of our society in our programs and outside of our programs that are not going to follow the rules. And that's very unfortunate, but that's where we are. And this has become a very politicized and divisive issue. It's very difficult.
Yeah. Thank you. So we're at time. I want to say thank you to our OMH colleagues, Dr. Kasoy and Moira and Donna and Chris and others who have joined. And thank you for all the participants for joining in and for your questions. Again, thank you, everybody, and I just wish you a great rest of the day.
Thank you.
Take care. Thank you. Take care, everybody.